Good evening, everyone, and a very warm welcome to this insightful digital symposium hosted by Veiva Scientific in collaboration with 𝐭𝐴 We are honored to have all of you here with us this evening as we dive into this critical topic of managing complex PCI with Impella. Before we begin, I would like to extend my gratitude to our esteemed panel of moderator, speakers, and experts for taking the time from their busy schedule and to share the knowledge with us today. It's truly a privilege to have such renowned physicians, both from India and across the globe, with us. We have with us today Dr. 𝐻𝐼𝐿𝐻𝐿 as our guest faculty and speaker. Professor 𝐻𝐼𝐿 is a renowned cardiologist and professor of medicine at Charles University, Prague, Czech Republic. Thank you, Professor, for joining us here today. Now, to guide us through this evening session, we have the pleasure of having Dr. Praveen Chandra Sir, the Chairman of Interventional and Structural Heart Cardiology at Medanta, Medcity, Gurgaon, as our esteemed moderator. Once again, thank you everyone for joining us today. Without waiting any further, I now hand over this platform to Praveen Chandra Sir. Sir,
thank you. Thank you, Gauravi, and it's a pleasure to have such a esteemed panel here, colleagues of mine, and also Dr. 𝐻𝐼𝐿𝐻𝐿 from Czech Republic. So I believe Dr. 𝐻𝐼𝐿𝐻𝐿 has to leave early because he has a flight to catch. So are we having his lecture first? Yeah? Okay. So we are now embarking on this journey of managing complex PCI, especially with mechanical circulatory support using Impella. So we'll have case presentations. We will have a focus lecture on the best practices by Dr. 𝐻𝐼𝐿𝐻𝐿 first of all, and then followed by my colleagues Ankush, Sharath, and Arun Kalyan Sundaram. So Dr. 𝐻𝐼𝐿𝐻𝐿, you can start now. No waiting for you anymore.
Yeah, thank you very much, Dr. Chandra. It is my great pleasure and honor to be with you tonight. For you, it's still afternoon in Europe, but I'm honored to give a talk on using protected PCI as one of our approaches in revascularization. So, as you all know, and as we live in the world of revascularization, revascularization improves outcome in all these settings: stable coronary disease, stable STEMI, non-stable STEMI, non-STEMI in cardiogenic shock and cardiac arrest. So many of those patients are actually so-called high-risk patients, and in those high-risk patients, we have to use advanced techniques to improve their outcome. And those advanced techniques actually allow us to prevent catastrophic events, and also to allow us to use the techniques for longer dilations, for a preparation of the lesion, for the better result of the intervention. And when you have a better result of the intervention, of course, you will have a better result and better outcome of our patients. So first of all, usually we aim in our patients for complete revascularization. And it has been shown many times, and this is the largest observed trial meta-analysis of all the randomized trials and observational studies, showing on more than 80,000 patients that complete revascularization actually improves the outcome of the patient. So complete revascularization, and you can see in all studies and the final result favoring complete revascularization. So as much as vessels is opened or dilated makes better for the myocardium. And this is the main dogma we do have in interventional cardiology and revascularization generally, that the maximum possible, it means complete revascularization, is the aim. And it's mainly in stable coronary disease, but with a proven viability, of course. So this is important. So we stopped using the term high-risk intervention because today we use and we prefer the term protected PCR, protected intervention. Why is that? Because the high-risk intervention meant that you are high risk and then you can get a complications. But in protected PCI, we are trying to prevent those complications. But still, if you have a patient who refuses cabbage from whatever reason, or the surgeons refuse cabbage, it doesn't mean we are not going to have complications during the PCI, because it's still high-risk patient. And the risk is usually associated with a combination of a coronary disease complexity and the clinical profile. So left ventricle dysfunction, age, presence of comorbidities, previous PCI or cabbages, and of course, calcifications and peripheral vascular disease are the main parameters we have to adjust to assess the patient risk and possible complications. And also the anticipated procedure complexity, whether we intervene on the left main or whether it's simultaneous multivessel disease intervention, what is the expected time of ischemic risk, so many dilations usually we need to do. Sometimes we need to do a complex lesions with bicoronary injections or ablations.
Recording stopped.
And other adjunctive techniques which may cause complications during the procedure.
Recording in progress.
So this is a nice overview of the criteria for considering patient for a protected PCI, and there is 3 of them. It's patient-related criteria, coronary anatomy, and hemodynamic status. So as said before, briefly, of course, age, presence of heart failure, and significant left ventricle dysfunction, prior cardiac surgery, concomitant valve disease, and chronic comorbidities are the parameters we should take into account when indicating protected PCI. Then the coronary anatomy, mainly the unprotected left main and the last remaining vessel, or actually intervention through the last remaining vessel in the CTO cases, very calcified lesions, which need a prolonged rotablations, long lesions, and of course also the complex bifurcation lesions where we use a double stent technique or double balloon techniques for dilation. And hemodynamic status, again, we should be sure about the hemodynamic status of the patient before the procedure. So we usually measure the left ventricle end diastolic pressure in those patients who are over 15. We should consider at least to have support ready in those patients with severely depressed cardiac output and left ventricle dysfunction, with those who generally have a low mean arterial pressure, and in those patients who have a large area of myocardium at risk, or in those patients who have an anticipated prolonged ischemic time. And there is also a characteristics for coronary anatomy. So elective 3-vessel disease with PCI planned or more than two vessels, distal left main, unprotected one mainly, last remaining vessel or last remaining graft, chronic total occlusions, which have to be intervened through the last vessels, are very risky interventions. And again, bifurcation techniques, two-stent strategy, or severe calcifications, which has to be treated with advanced atherectomies or intravascular lithotripsy with a shock wave. So this is major considerations. So what do you mean? So you define the patient who is a candidate of a high-risk PCI, has those features. Then this should be discussed thoroughly in heart team to discuss whether the patient is or is not a candidate for surgical revascularization, usually is not. And then the patient is being indicated. And we always do this in the heart team to be sure that this is a shared responsibility for elective cases, and mainly that we proceed with either protected PCI, which means that the patient is implanted with a mechanical support before even started the PCI, in contrary to standby mechanical support during the PCR or rescue. And always, if you need a rescue mechanical support during the PCI, it brings more problems. So protected PCI means upfront use of mechanical device. And this is the consensus document which defined actually exactly those patients who should be at least considered for protected PCI. So unprotected left main and severe coronary artery disease, it means patients with Syntax score of over 33 and severe left ventricle dysfunction below 35%. Honestly, we are usually even more with ventricle dysfunction. So in those patients who are over 35, over 40, we are a little cautious, but in those who are below 30%, we always use Impella for those patients, and also for those patients in a case of a so-called CHIP, which is a very complex high-risk intervention procedure. In unprotected distal left main with a syntax score over 22 and severe dysfunction, those are patients which should be indicated for protected PCI. And again, we aim for complete revascularization, as stated well in this document. Complex CTO means that you are intervening CTO usually retrogradely or using bilateral injections in patients with severe dysfunction or in patients with the single remaining vessel. Those are patients who are suitable for protected PCI. Last remaining vessel intervention, again, it's an intervention where you have to be very careful. Diffuse and calcified lesions for prolonged dilations, where we need to prepare and crack the plaques for later stenting. Patients who are in high risk of slow or no reflow phenomena, those are patients where sometimes the MCS is indicated as a bailout strategy, but this is usually much better if we are able to be implanted before. For the bailout strategy, there is a intermediate kind of a step. We call it standby, and the standby means that you prepare the access in the vessel before the procedure, and then you are ready with the cannulation. So you don't need to cannulate a second access for mechanical support. So you keep your virus in place, and then you just use your pre-cannulated sheet for insertion of mechanical support, being it Impella or ECMO, concerning the hemodynamic status of the patient. So we usually use Impella if the patient is slowly deteriorating or having some repeated arrhythmias. But if the patient crashes completely, has cardiac arrest, then we go with VA ECMO. And this is basically covered in the previous. What kind of evidence we have? Unfortunately, there is not so much evidence for protected PCI. There is ongoing trials which will show evidence soon, but we do have a PROTECT 2 and PROTECT 3 trials mainly. So the PROTECT 3 trial, which I'm going to talk about, is a prospective multicenter study which compares the population from this prospective study to PROTECT 2 randomized controlled trial arm of patients who have been treated with Impella. As you know, PROTECT 2 trial was a randomized trial which compared Impella 2.5 versus balloon pumping. This study missed the primary endpoint of the 30 days MACE very tightly. However, there was a benefit in 90-day MACE rate in patients on Impella 2.5 versus those patients on balloon pumping. And this led to the FDA approval of Impella for high-risk PCI or for protected PCI. And then PROTECT 3 compared to those patients their outcomes. So this is a nice comparison of a new population in a more developed setting of interventional cardiology versus the historical controls. And you see the PROTECT 3 patients had more triple vessel disease. They had more severe calcifications present. Their lesions were longer. The atherectomy was used much more often in those patients, and mainly the syntax score was worse. So this was even worse population for intervention. And as you can see here, the results, the blue are the PROTECT 2 and the green are PROTECT 3, and this is the occurrence of MACE. So there was a statistically significant decrease in the MACE in those patients treated with Impella in the PROTECT 3 arm. And as you can see over here, comparing balloon pumping versus Impella in the PROTECT 2, there's been decrease from 22 to 17% of the major composite adverse cardiac and cerebrovascular events in the PROTECT 3 trial. So this is basically the only randomized and propensity matched population study which provides clear evidence for benefit in protected PCI cases. There has also been a nice echo sub-study of a PROTECT 2 study, which has shown that those patients who had a viable myocardium and became the reverse remodelers, this is right here, they did have much less of the composite death and MACEs like death and MI stroke. And TIA, and also those patients who had reverse remodeling and increased their ejection fraction of more than 10%, they had basically no adverse events. So it means that if the revascularization is successful, if there is a improvement in the ejection fraction of those patients, then the patient profits the most. And again, taking opposite, it should be proven that the patient has a viability in the myocardium before we perform such a complex procedure, mainly in patients with CTO. So this is very important. So why we actually provide and why we do protected PCI? First is to avoid hemodynamic catastrophe. So let me show you a video from our Cath lab, which is kind of a weird. You will be probably surprised by this video, but you can see the rhythm on the monitor's ventricle fibrillation, and the patient has cardiac arrest. But if you can see over, and I hope you can see well, the patient is still awake, talking with me during the procedure, still having cardiac arrest. And this patient is on Impella, and the Impella support of 3.2 liters per minute. So you see my colleague was taking a video in this acute case, and you see 3.2 liters on the Impella console is enough for keeping patient awake. And this is something completely new. And this is a new change in the paradigm, that the patient who deteriorates during the procedure, this patient had a non-STEMI with a cardiogenic shock. We put in the Impella, and then during the procedure, he arrested. So you can see nicely that if the patient arrests during the procedure on a running Impella, there has been no change in his consciousness, and he didn't have a hemodynamic collapse. So this is important. And the second is in protected PCI to allow lesion preparation, because what happens, this is a patient tracing from the protected PCI of a proximal LAD dilation, many dilations to deal with a calcified plaque. You can see this is a nice tracing among the dilations, but once we dilated the LAD, you immediately see the loss of pulsations and immediate decrease of perfusion pressure. So if this happened without mechanical support, we would probably be in a big trouble. So this is the main reason why we do protected PCI, and this is our protocol. So we always go in a hard team discussion, and we indicate either PCI or CABG. If PCI is indicated, the procedures are executed during the morning hours, that everybody is fresh. We always have perfusionist in the Cath lab who helps us with the Impella or VA ECMO if needed. We usually use a femoral approach for MCS and the radial for PCI, but in cases we work with Impella, we use usually the single access through the Impella sheet. We always use the safe puncture approach for femoral cannulation, so it's combined X-ray and ultrasound cannulation. We always use pre-close technique with ProGlide sutures, or in some patients after removing the cannulas, or even for Impella, we can use also Manta. But the ProGlide stitches plus angioseal is our first choice for closing the large bore access. And we use mainly Impella CP or VA ECMO in those patients who have a contraindication for Impella, like patients with aortic stenosis. So let me guide you very briefly through the access site management, which is a prerequisite for success in protected PCI. First, the most complications are bleedings, and this is a nice overview how bleeding actually worsens the outcome with a high incidence of bleeding, severe bleeding, interventions resulting from bleeding, and intervention because of the access site-related ischemia. So this is complications you may face if you use mechanical support in patients. This is how to actually cannulate. So we always use ultrasound. As you can see on the right-hand side, we find the common femoral artery, we find the bifurcation, and then always check the artery for the needle entering the artery. So if you see over here, you see the bifurcation, the common femoral artery, superficial artery, and profunda artery. So to be sure that we are in the common femoral artery. And we also look for the plaques. So you see the plaques over here, and the plaque has to be avoided. So we always puncture outside of the plaque if it's possible. If you use a fluoroscopy, there is 5 zones, so you should go with the needle through the zone 5 through the skin, but to go to the vessel in a zones 3. So if you look exactly on the needle under X-ray, you see the cannulation over here, and just here in the middle of the bone, there is the zone 3 for the cannulation, then the wire insertion, and the final check of the position and the entering of the vessel. Because if you enter through the superficial femoral artery, it may cause a problem when you implant a large bore catheter. And this is the online puncturing. You see on the right hand side the needle entering the vessel on the anterior wall, exactly outside of the plaque. So this is important, not only just to find the vessel, but to find the tip of the needle to visualize, to find the anterior wall for the puncture, to avoid anterior vessel wall calcifications, to verify the wire position, and to recognize eventual complications. So this is very, very important, and been shown many times in TAVI and the other large bore accesses that ultrasound guidance improves the outcome. And then, of course, in patients who remain on mechanical support, we have to monitor them. So this is the way how we monitor in ICU. So we make the markers of the position. There is a ECMO implanted in this patient. We have an Impella protocol for flow and purge, and this is always checked by perfusionists. We use nurse always to measure the perfusion of the extremities. And we, of course, have to differentiate between cannula-related obstruction and hypoperfusion. That's important. And if nurse is failing, then we perform Doppler ultrasonography. And this is the nurse probe on the extremity, and this is the nurse values that we monitor. Concerning ischemia, this is always a big problem, which can be solved in ECMO because you can puncture the prograde cannula, but it's much more complicated in Impella. So let me show you this case of the lady who had a bilateral limb ischemia on Impella CP. The lady came in with a cardiogenic shock, was implanted with the Impella. You can see the Impella implanted from the right groin right over here, and she developed ischemia because she had tiny vessels. So we implanted distal perfusion and took the sheet from the other side to perform like a bypass from the left to the right side. But implanting this 9 French sheet actually caused the ischemia of the left limb. So that was a reason why we implanted the 14 French sheet here to the left hand side and did the bilateral bypasses percutaneously to avoid ischemia of the both legs. So this is one of the ways how you can solve ischemia. The other ways would be surgical, and it may cause a trouble in a patient like this. And here you can see the patient later on the Impella 5.5 rehabilitating and walking around the unit, still totally dependent on Impella 5.5, and later on implanted with a left ventricular assist device. So let me conclude that the protected PCI allows interventions in a high-risk population and prevents hemodynamic compromise during procedure, and also allows prolonged lesion preparation. Bleeding and vascular complications increase mortality and morbidity, and we have to try to avoid them. Safe vascular access and closure is critical and essential for good outcome. Combination of ultrasound and fluoroscopy guidance and angio is of utmost importance, and monitoring early recognition and management of complications is crucial. And then finally, the percutaneous closure is safe and effective, but I didn't have a time to go deeply into this. So thank you very much for your attention.
Thank you, Professor. That was a very nice overview of the uses of Impella in protected PCI situation. And what is your experience in patients who have got cardiogenic shock, and how quickly you would get Impella in these situations? What is the decision to implantation time in your lab?
Yeah, so the implantation time with Impella is really short. We are a large ECPR center, as you know, and we are doing a lot of patients in cardiac arrest and cardiogenic shock, so we are quite trained. And we have a specialists who are just specialists for eCPR, and those people are well trained for very fast cannulation. So I would say realistically that if you have a patient who comes in cardiogenic shock, you do have a perfusionist in the cath lab, you should be able to implant Impella within 10 minutes from the point that you say, yes, we implant, to the point that the Impella is flowing. You may do it shorter, but important thing is that you are kind of ahead of the thing. So our approach is the upfront implantation in patients with cardiogenic shock following the danger study results. So if you have a patient in a profound cardiogenic shock and you know that the coronary anatomy is very, complex, then there is no reason not to implant the Impella. So we implant the Impella and then we proceed with PCI. And it should be done 5 to 10 minutes, and it's usually manageable.
And the uses of ECMO you showed in some cases also was required. So what would be the percentage of cases where you needed concomitant ECMO as well?
Yeah, sure. As you know, there's been a couple of studies, including ours, that failed to show that ECMO improves outcome in STEMI-related cardiogenic shock. But I think we have to know that the patients are heterogeneous. So still, Impella would be probably, after danger, the first choice. But Impella is perfect for 𝐻𝐶, maybe 𝐻𝐾D patients. But even if you look to the danger shock study, 12% of patients who were put on Impella, they crashed and they needed rescue ECMO. So you have to be always ready for those patients who are crashing, either spontaneously. So patient comes into your cath lab, has 60/40, you do the first injection, and then the patient crashes down, has cardiac arrest. This is a patient for ECMO. If the patient comes in, is 𝐻𝐶 70/50, you do the procedure, put on Impella, and then the patient develops arrhythmias, crashes, and simply Impella 3.5 liters of CP is not enough, then you upgrade to ECPella. So this is important, that saying that the studies were negative ECMO doesn't mean that there is no patients for ECMO. There are. Those are patients who are severely deteriorated, who are in a profound cardiogenic shock, where 3.5 liters may not be enough. So that would be my answer to your excellent question.
So how many patients, that's a good question. So how many patients of cardiogenic shock in general where you have to escalate to ECPella? And what are the situations where you do that?
It's about 15%, I would say 15 to 20% maximum. So still
You
80% of patients are
ECPella.
you have to upgrade to ECPella, and you have to be ready to upgrade them to ECPella. And it's simple, because some, it's usually big males, they need a lot of flow, and simply 3.5, 3.8 liters are not enough. But in other patients who have a sustained spontaneous cardiac output, you help them with Impella 3.5 liters, this may be enough. So for the majority of patients, it's okay, the ventricle is unloaded, myocardial damage is, decreased, and it should be enough. But in some of those patients who crash and who develop severe deterioration, then you have to upgrade. And then what you do is you maximize your ECMO flow and you use Impella for unloading of the left ventricle. And then usually we wait like 2-3 days, and then we switch back again. We try to wean ECMO and keep those patients on Impella again.
Good.
But maybe your question is, and I think it should be stated, that every cath lab which is dealing with cardiac arrest and cardiogenic shock should have both those devices available for the crashing patients.
Yeah. So any other questions from my other colleagues? Yeah, Dr. Bali. Yeah.
Yeah. How common is your right heart catheterization in such patients of impending cardiogenic shock or cardiogenic shock to decide about ECMO or decide about how you're going about managing such patients? Do you routinely use right heart catheterization or only in selected patients?
That's a good question. We are very conservative on that. So if you compare us and the United States, in the United States, basically everybody in cardiogenic shock receives right heart cath, receives Swan-Ganz catheter. We don't do it routinely. We are kind of selective. But what is important, if you implant Impella to measure left ventricle and diastolic pressure before you implant the Impella. It's very easy, it's very fast. Then you can calibrate your Impella. And then if you calibrate your smart Impella, then you have a, filling pressures during all the treatment of the Impella. So you do have basically the most important part of the right heart cath, which is the left ventricle filling pressure, the wedge pressure. So you don't need to use exactly the Impella. And for the cardiac output assessment, we use echo and the VTI. So that's, I would say, easier. But there is some patients who are still unstable, and in those patients, we implant right heart cath.
So, Dr.
You will
Bali,
have
that's
some
a very
patient-
good point which you raised about the right heart. So, as far as our practice here is concerned, that in every case where I'm using Impella, even for protected PCI, I put in a PA catheter, because it is
Yeah.
much, it's like 200 rupees, 500 rupees, something like any multi-purpose catheter can go in while you're doing the procedure. And it gives a very good information about the fluctuation of PA pressures while you are doing the intervention. And you can then, kind of optimize your treatment strategies. So
you
I
would also
always
like to
use,
know the right ventricle function as well.
yeah.
You would also
And
like to know the right ventricle
yeah,
function as well,
yeah.
because
So
many of these
the
patients
RV
may have a right
Yes.
isolated right ventricle dysfunction.
Yes. So in these cases, always when I'm using a patient for cardiogenic shock, always SWAN is not so expensive, at least, So if you're using such expensive devices, even the cost of SWAN is lesser than the cost of 1-day ICU these days.
The
So
cost is not a
That's
factor, the
correct.
utility is
Yeah.
the factor. Understanding that it gives you
yeah,
information is more
yeah.
important.
So I think we now know that SWAN, the right heart catheterization is important.
Yes, definitely. For the right ventricle assessment, it's a gold standard. But always, if you have a patient coming for protected PCI, you always had echo before, so you always have the value of right ventricle function. And sometimes we even have a patient with the right heart before they are indicated for the protected PCI. So this is very valuable, of course, and you can guide the therapy based on the PAPI index very well. Yes, I agree. Sure.
I think RV function assessment is important, as he's pointing out. PAPI less than 1 or CVP pulmonary wedge ratio more than 0.6. You have to be prepared for biventricular support, either to begin with,
Yes.
or you might have to add on
Exactly.
as you move forward. That's important.
Exactly, that's an excellent point. But then, if you face this problem, it becomes complicated. With right ventricle support, it's much more difficult than with the left ventricle support. But we have done a couple cases with the Impella RP. We have done a couple cases with Protect Duo cannula, and it is still possible to do it. Yeah.
Yeah,
Sure.
RV failure is very refractory, doesn't respond so well, and it complicates issues. Yeah, correct.
Unless until it is a RV infarction during a
Probably it happens, big RV branch going off, and it causes problems.
Yeah, exactly.
Okay, so I think we can
Thank you
move
very much.
on to the next presentation.
With pleasure.
If there are no more questions, thank you very much, Dr. Jan. And we'll move to some very interesting experiences. Dr. Ankush is the first one. Dr. Ankush.
Sir, good evening.
Hello, hello. How are you? Please carry on.
Sir, is my slides visible, sir?
Very much.
The topic for today's presentation is protected PCI with Impella. I think Dr. Jan gave an excellent overview that we should know when to, convert our high-risk PCI to protected PCI. To prevent catastrophe happening in the cath lab. So I'll share with you one case in which was high risk. It remained high risk, and then we converted into protected PCI. So this was 71-year-old male, known case of diabetes mellitus, hypertension. He had a rest angina on 1st of September 2023. Then he came to us. ECG showed ST elevation. He came to us after 1 day. ECG showed ST elevation avia, diffuse ST depression in chest leads. 2D echo showed severe LV systolic dysfunction, LV territory severely. In fact, all the territories were hypokinesia. There was hypokinesia, and the thickness was preserved. We did coronary angiography that showed the calcified TBD with RCA-CTO, LCX 95%, LAD 95%. So this is the angiogram. You can see that LAD is heavily calcified in the mid to proximal part. And in the second angio, you can see that large OM is coming from this LCXH, again a heavily calcified vessel, around 95% occlusion, and RC was CTO, and RC was filling retrogradely from the left injection. So practically the LAD was the vessel that was supplying to the right coronary artery also. So in this case, we thought let us go ahead and do first RCA-CTO, followed by, we knew that it's a high-risk PCI, so we thought let us go ahead and do RCA-CTO, followed by stage PCI to LAD and LCX. We thought of IABP. We kept the IABP standby. We took a femoral access, 7 French AL1. We took the pilot 200 that crossed the lesion. After crossing the lesion, it was planned to see that it was a heavily calcified vessel. We planned for upfront rotational atherectomy, but microcatheter was not crossing. Then we did the saline lasing, microcatheter crossed. We exchanged with the rotawire, and then we did the rotablation with the 1.25 bar. When we started doing rotablation, patient developed pulmonary edema, for which he was electively intubated. Patient developed complete heart block, for which TPI was placed and his pressure dropped, and for which you can see that a patient started on inotropes and IABP was placed. So in fact, by this time, patient was on triple inotropes. So this was a calcified TVD, severe LV dysfunction. We started without any support. We had to come to the IABP, but at the expense of near catastrophe, pulmonary edema, complete heart block, and hypotension requiring 3 inotropes with IABP support. So the case was abandoned. We thought of going ahead, but the patient was really sick. The case was abandoned, shifted to ICU on mechanical ventilation with the TPI, triple inotropes, and IABP support. Then patient was managed, and he got extubated after around 48 hours and discharged to home after 7 days. So he was discharged to home. He was doing good. He was now this time, thinking about a repeat attempt for revascularization. More than us, the patient was quite, scared of what happened in the lab, and he was doing very well with the, guideline-directed medical therapy, and he again had a rest angina, and he again presented to us after around 6 months on 18th of March this year. So this time we reassessed the patient. So patient had a severe LV dysfunction. He had a ACS twice, calcified TVD, large myocardium at risk. We discussed with the heart team approach. He was turned down surgically. That it's a very high risk case, so it was surgically turned down. Syntax score was more than 32. He was known case of diabetes mellitus and hypertension. So all these factors, pointing toward that, and the previous experience with the case, we knew that this case now require a protected PCI, no more high risk PCI. So we thought of going for.
There is some disturbance. I think someone should just put the mute. Mics on mute.
I think we can mute everybody except me if possible.
Yes,
So we thought of, okay, we knew that this patient had enough of high risk PCI. Now seeing the parameters, seeing the patient comorbidity, hemodynamic compromise, and the patient condition, we knew that patient shouldn't go for a protected PCI. So we thought of going for Impella CP Smart supported, PCI in this case. So this was the angiogram after 6 months. LAD was in the same status, but again, another CTO that LCX that was 99%, now it's cut off. And this time the RCA, the amount of flow that we achieved last time, it was gone. So again, the RC was CTO. So we started with we placed the Impella CP device. And we knew that when we were touching RCA, patient will have some hemodynamic instability. We placed a TPI also in this patient, and then we started with the RCA again. So far we tried Fielder XTA, Gaia, first Gaia, second Gaia, third, and after around 1.5 hours of attempt, there was we found that there was a wire puff in the mid RCA. So here patient was on Impella. We waited for some time. We found that there was no pericardial effusion. There was some staining. We thought, let us go ahead and do left side and do a single surviving vessel. In fact, in this case, the LAD was the sole vessel which was providing collaterals to our right side and maybe to the rest of the L6 territory. So in the left side, we again went ahead, wired the vessel. We did rotablation, first with 1.25, followed by 1.5. And after doing rotablation, when we started doing rotablation, we found that there was significant amount of VA uncoupling. So in these kind of cases in which there is critical TVD, or you are touching the touching the last remaining vessel, whenever we do intervention of this kind of vessel, there is a significant amount of LV hypoperfusion leading to stunning of left ventricle, and in these conditions, LV is not able to overcome the afterload, and this can very well seem in this kind of case that there is hardly any aortic pressure, there is hardly any vertigo, there is some ventricle contraction, but that is not translated into aortic waveform. This is known as VA uncoupling. But Impella is unloading the LV at this time with the cardiac output of 3.7. So this is the one of the advantage of using Impella in these kind of cases, in which that touching left main in left dominant circulation or critical single surviving vessel, that this is the most crucial time where actually Impella support the myocardium, it supports the hemodynamics and perfusion of the coronary artery as well as of the other part of the body. So this is the IVUS run after rotablation. I'll not go into detail. You can see in the L mode there is a large amount of calcium. You can see there was some 360-degree arc of calcium, 1 or 2 crack can be seen. So we went ahead, we did use the IVL as per the target vessel diameter. We used the 312 IVL. This is the IVUS. In a calcified vessel, now we are dealing with a single surviving vessel at present, on which the patient is going to survive. And this is a time when Impella is actually supporting us, and it's very important to do image guided PCI to see whether this calcified bed has been optimally prepared or not. So we did use IVL, we did the IVUS, we saw the large number of fractures, and even in the L mode you can see there is significant amount of lumen gain here. Then we use a cutting balloon, and after doing doing pre-dilatation with the cutting balloon, we used 2.75 34 stent from distal to mid LAD, and another stent of 3.5 to 34 from left main to LAD. This was port was done with the 4.5 12 balloon as per the size of the vessel, and the LAD was post dilated distally with the 3 and proximal with the 3.5 of non-compliant balloon, and this was the port being done. This was the final result. By this time, already around 4.5 hours, as we were in the lab, and this time patient didn't develop any hemodynamic instability. You can see that tightest point that was after rota 2.1, now it has increased to 7.6. So stability was 9.5. Left main was around 13 millimeters square. And this was the post-rota, post-IVL, post-PCI runs. So in this single surviving vessel, heavily calcified, we use rota, we use IVL. We documented the bed preparation with the IVUS, and after that we placed the stent and optimized we acted on a imaging, and we saw we left the patient with a good area. This is then patient, it's very important. In fact, my first patient that 6 years back we did in the base hospital, Delhi, that was again a severe LV dysfunction, left main bifurcation. We weaned that patient on the table, and the patient didn't make it. So it's very important that one should not be in hurry to to take out Impella, especially in a complex intervention with severe LV dysfunction. So patient was shifted to ICU. This is the chart how we monitor our Impella patient. Same night, we thought of going again to the RCA, but I think it was correct that we didn't do anything. Same night, patient developed massive pericardial effusion with tamponade effect. Pericardiocentesis done. 250 ml of blood was drained. Impella was maintaining good cardiac output. Urine output was good. After 24 hours of full support, myocardium contractions started improving. On day 3, inotropic support reduced to 0. Impella expanded after around 48 hours of support in the ICU, and patient was discharged after around 5 days. So at the 6 month of follow-up, in fact, last week only patient came. He's in NYC class 1. He has got his Apple Watch. He's, doing his 10,000 steps daily. His EF is 35%. So my take-home message is that in complex PCI, high-risk PCI, one should have an institutional protocol that when to go for protected PCI. Every complex PCI may not require MCS support, but at our institution, single surviving vessel, left dominant, left main bifurcation angioplasty with severe LV dysfunction, triple vessel intervention, again with severe LV systolic dysfunction. We usually go for protected PCI. With the use of protected PCI, there's a less hypotensive events, and one can afford to go for a prolonged procedure, rotablation, IVR, prolonged balloon inpatient. Don't be in hurry to expand the patient on table if the procedure is too long and you can anticipate unstable hemodynamics. So at our institute, we follow that if a patient, hemodynamics are stable, even if the patient has got a severe LV dysfunction, we usually don't, wean the patient in the lab. And patient monitoring in ICU is crucial to get the best outcome when using these kind of hemodynamic support. Thank you very much.
Ankush, I think this was a phenomenal case. One can generally, not expect anything better than this. This was almost like, you were doing the last remaining vessel. The 𝐸𝐶 and RCA both are good. So without Impella, it would have been very difficult. And certainly, let me, take some more comments from our other colleagues. So is there Dr. Bali and Dr. Kalyan and Viveka? Everybody is here. So let's see what is their input on this case. Whether anybody would have done different.
Always. Yeah. Only one point I'd like to make, that in the first case, when you were doing the right coronary, and you had chosen to do a rotablation in such a patient, would it be better to go with the Impella right at the start? Because it's such a severe left ventricular dysfunction, and you're doing a CTO and you're doing a rotablation, even a small amount of slow flow could have shifted the balance. So that is one thing. If you had chosen to do a CTO on the right side with a rotablation, it may be a better idea to go with the protected PCI in the first instance itself. So that's my one comment.
Absolutely right, sir. That is what we learned from this case. So this was actually first time we were doing high risk PCI, but this patient actually required protected PCI. That point of time, we thought that we may get away doing a RC CTO and we may go for left side later on. But this is theoretically all the algorithm they shows in this kind of case, it required protected PCI right from the beginning. And you are absolutely right, sir.
Yeah, but at the same time, what Ankush, you are saying is also right, that when we are doing CTO, generally people believe that if you are doing a CTO, but Dr. Bali's point was right, that if the EF was so low. So I think that was a nice point.
Yes.
Yeah, someone was pointing out something. Dr. Viveka, who's there?
Yeah, so I think the very well done cases, and we must say that it was good save. And sometimes we see that you do without protected PCI, but as Ankush said, that sometimes you feel that probably you might get away with that so that you don't have to spend so much in the case. So you learn from your cases, but sometimes the judgment may err on the side of not using it and then you repent it. So that happens every time, whenever these complex cases are there. But I think end of the day, it is well done and we must congratulate him.
Yes. Yeah.
Great case.
So thank you, Ankush. I think
Thank
we
you, sir.
can move on to the next presentation. And I think Dr. Sharad or Dr.
Thank you.
Kalyan, whoever is ready.
Yeah, I gotta go, guys. I have a flight to catch if that's okay.
Every time you are on a flight.
I know my life sucks.
So please carry on. You're
Thanks,
absolutely
Sharad.
fine.
But actually, even in the order, it is supposed to be me though, but that's what I was told at least. So it doesn't matter. It's fine. Thank you, Sharad. I really appreciate it.
Go ahead.
So yeah, can you guys see it? Yes, no, maybe so.
So you can share your screen now.
We can't see your screen.
I am working on it. Okay. There. Do you see it now?
Yeah.
Yes.
Go ahead.
So let's see. How do I get this to be slide? There we go. Okay, good. So first, yeah,
Make it
I was
full
going to
screen.
comment on Dr. Ankush Gupta's cases. It's like amazing work. Great job, man. So yeah, so my experience here, I would say in India at least, has been like pretty much limited to protected PCI. It's really hard to convince patients when they are in cardiogenic shock about a pretty expensive piece of equipment when they may or may not live. So yeah, at least my experience has been limited to this. And in fact, it's very interesting. I think, barring, I think, 2 cases, every other case had VA uncoupling. So I think case selection has been good. We didn't use it for fun. So yeah, I mean, this is a slide that I think most of the audience is really, are familiar with. My question was like, my own experience. I think the key point, I'm not going to go to the how and why, because I think that's kind of stating the obvious. But the most important thing is that, for high-risk PCI patients, the chip cases, these patients are undertreated, they have high mortality, and I think doing protected PCI and complete revasc, or at least complete functional revasc, really helps improve outcomes. Okay. So in general, again, this slide has been, I think, kind of shown before in the talk, but a couple of components. You talk about the anatomy, you talk about the comorbidities, and you talk about what you're going to do. Like the discussion about, hey, I'm going to rotate the last remaining vessel, maybe you should consider it, etc. So, a couple of factors that go into play. There are scoring systems, including one, I think, that's published in Asia Intervention, that's for India. But in essence, follow some scoring system. At least it'll give you an idea about how to go about in a methodic manner about like which kind of patients might most benefit from it. So I'm a simple guy. One of the things that I say is the patient unstable, then yeah, you should consider it. Is there enough of a reserve to sustain a brief ischemic result? The answer is no, then I would consider it. During the procedure, is the patient at risk for interruption of blood supply that can lead to a big collapse? Then if the answer is yes, again, I would consider it. And the other thing too is that, like, are we talking about, is this case going to be like a retrograde case in a poor LV, and I'm going to have prolonged ischemic result, and then, it's basically going to just mess up the LV? If the answer is yes, then use it. If not, I'm prepared for it anyways. But I think the other point that was brilliantly made, clearly data has shown that early upfront use of MCS is way better than doing it in an emergency in terms of outcomes. So this, again, is I think, familiar slide to a lot of people. Impella is probably the only one that helps with increasing coronary perfusion and decreasing myocardial oxygen demand. Now, I have only 10 minutes, so I'm going to skip the first case and just go on to the second case, okay? So this was a 64-year-old male patient that, had horrendous LV with 3 calcific vessels and 2 CTOs, EF of 19, but apparently everything is viable. The surgeon on a heart team discussion clearly said there's nothing for me to graft. And there were some complex family dynamics, but long story short, that's what you're seeing, LAD CTO, RCA CTO, and you see the circ. So that's the right. So I'll just kind of show you simultaneous shots. So I kind of thought, okay, this is a pretty cool case. And actually, just the guy was not poor because this is a protected PCI, but he definitely have a lot of money. So this is just that, okay, Impella is being played and all this good stuff. So Impella was in position, and oh, lo and behold, I tried, and I thought LAD was going to be straightforward. At least, like, there was the whole plan, but I did go into the plan, but did a couple of things. But really, what I wanted to emphasize was this was a case which was one of probably my second most dramatic case, because I thought, oh my God, I don't have wire across. I have a huge LS3 perf. The guy is like not good. But for Impella, this guy would have died. So actually, I did call the surgeon, went through the whole usual stuff, but once again was a turn down. Actually, ended up doing base. And I guess I did a lot of, like, I've done left mains, atherectomies, etc. But since I'm supposed to, like, I don't know, I always show CTOs. So I ended up doing base, and then here you'll see the knuckle go further down, and I'll just go to the end of the thing. And there are just knuckles start my way into the LAD. Okay, so that's, let me just go to the end. Yeah, so there you can see it go in. So now DCB in the distal part, and I actually stented just this with a regular, it's not a covered stent, it's a regular drug-eluting stent. So this problem was kind of taken care of. The perf was sealed. And for those in the audience that are not super familiar with what we did, essentially this is what it was. Go into the subintimal space, leverage the subintimal space, use that flap to essentially seal off the dissection. Okay. So then I also decided, given that I did lose the diagonal branch, to go ahead and fix the RCA too. And actually, that was the plan. I thought LAD would be a quick antegrade wire, and then I'll do the RCA in a retrograde manner. There are two reasons to do the RCA. One, like I said, wasn't thrilled with the LAD. And number two, if I stent across the septal, which is already diseased, which is retroflexed, it's going to be super hard to get back in. So I kind of just went back, guide extension reverse card. So all this was done. Okay, this is just it going into the guide extension catheter or something. There you go. Okay, good. So this is PCI, business as usual. Oh, you guys do see the pericardiocentesis thing and all that stuff, right? It's there. I had to do it right away. So stented, and then so RCA was done successfully. Then I just went back to the LAD to stent that proximal part that I told you was also diseased. Okay, so that's kind of how we left it. And then, of course, there's this very interesting discussion about where you leave Impella. This was a case where you definitely leave Impella in. Both the left and the right were good. I just did a check angio because I could, just to make sure. I mean, his pressure requirements had come down. He was doing pretty well. And then Impella came out. And so in the usual manner, close to the angio and a per close. And then, interestingly, in fact, honestly, I didn't even believe that his LAD was viable. Initially, I was like, I don't know, whatever the MRI says. But truthfully, right, he did well. This was a pretty long procedure. He did well. He didn't go into renal failure. He was in the hospital for 5 days. At 3 months, he had actually improved to like 45%, continues to do pretty well. So that's that. Oh, this was another dramatic case. I'll just be really quick about this. But once again, crappy LV with and the patient basically was one of those guys that just wouldn't take care of himself, and had triple vessel disease, denied bypass surgery. This guy was so sick. I mean, he came in cardiogenic shock, and then he had to be like, kind of taken care of medically, then brought back. I mean, he was like too sick to even like take anywhere. So we did an angio, and then we had to stop. So I'll show you the angio first. So here's the left. There, in fact, I didn't know how sick he was because my associate actually did this angiogram, and I'm like, holy shit. So this is pretty, I'm sorry. Yeah, holy crap, this is pretty bad, right? So both left and right are pretty crappy. So we said, all right, after a long time, we said, oh, let's do Impella and then, do this procedure because there's no way I'm going to do him without. This guy was so symptomatic. He couldn't sit up in the ICU without angina. So I got the wire in, and the guy basically went into arrest. In fact, immediately took it out, but then had to put everything back in pretty much during chest compressions. And then at the very end, you'll see it just pop back in. Okay, there. And then after this, it's very, I mean, this is just the TPI getting in, but you see that the heart function is gradually coming back, right? So this is good. And then, the PCI itself wasn't super hard, fixed the left. And the LAD in this case was not viable. So it was basically stented into the diag, circ, LF main, all that done in a complex PCI manner. And then given that this guy was doing so crappy, also decided to fix the RPL, which was also done, and stented the proximal part of the RCA and all this stuff. So that's how we left that. So once again, but for Impella, I think this guy would have died. There's no way I can continue to do CPR and do a PCI. So, I think we do have really, really sick patients in our part of the world. A lot of these are basically told that they have no options. I think these are precisely the kind of patients that also benefit most from protected PCI. Clearly, complete revasc helps improve EF as long as these therapies are viable. And it'll be interesting to see the results of Protect 4 as it comes out. Obviously, given our cohort of patients for protected PCI, even with Impella, you are going to have a lot of complex procedures, which means you need to know how to avoid complications, how to manage complications, and how to take care of yourself. With that segue, I will introduce, or rather welcome you next month to Chennai. All of you guys are invited. 9th and 10th of November to the Asia Interventional Complications course. Bill's coming down, Yamani Sensei is coming down. It's going to be a good meeting where you will learn a lot about complications and how to manage them, avoid them, etc. Thank you.
Thank you, Arun. I think this was a phenomenal, display of your skills, and of course, using technology for these very sick patients is very, very important. So, any comments or questions for these cases or on Arun's lecture? Anything, Manoj?
Yeah, wonderful
Hello.
case, and particularly the cardiac arrest patient whom we could introduce the Impella while the external cardiac massage was being performed. I also I was bus driving till now, so I just listened to the international faculty who did say that the patient was conscious with the VF going on at the Impella Institute. I have a different take on that because I've seen that patients who have an persistent VT and VF or insistent VT and VF, there is no filling of the ventricle happening. So when you don't have the volume loaded on the ventricle, because Impella is a preload sensitive device. So if you don't have a preload, there will be diastolic suction alert and it will be not effective enough to sustain the hemodynamics. And you may have to scale down on the performance levels of P2 to from P8 to P6 or P5, which would hardly sustain a flow of around 2 liters per minute. So the whole purpose of putting an Impella to not getting a robust hemodynamic support would be vitiated if you don't have an adequate preload. So if the patient has a asystole or a VT or VF insistent and is refractory and you've given multiple shocks, 8, 9, 10 shocks, and still continuing, that's a situation that I would always convert into a VA ECMO, and then that will provide a good unloading of the ventricle also, because you already have an Impella inside. So that's something that I would always consider and not allow the patient to be in VF while the Impella is inside. So what was the clinical scenario, Dr. Arun, when patient was arrested, and what were the pressures? And did you get any diastolic suction alert during that time?
No, actually, the machine was not even in. So what happened was, got the pigtail, got the overnight wire, take this out. I'm like, okay, I'm gonna get the Impella in. So when the wire was there, and as it was being loaded to go in, I'm like, shit. He went into it, right? It was a couple of PVCs, and actually went into, like, pretty much there was nothing. So and we quickly got it in, but still happened. Like initially when he cracked it out, and we thought, okay, maybe this is just irritating something. Let's just quickly get the wire out, and then nothing happened still. So at that point, I'm like, okay, nothing is. I have to get something going. I have my options at that point really quick. I have an Impella that's open on the table, and I mean, the guy's already paid for it. And the other thing is like, okay, thinking TPI, we got to get something going. So chest compression started, and thought, okay, get some LV, get the stuff to get going again. So that's why I had to, like, put the Impella in under arrest. So we didn't actually have stuff when he arrested. Just the wire was inside when he basically stopped. I mean, the guy's reserve was crappy. I mean, I have seen lots of bad angina. This guy in the ICU on therapy couldn't, when he sits up, like literally, he's lying in bed like this. He sits up, he's like, I have chest pain. I have chest pain. So, I mean, I don't know. It's just bad. Sorry. Yeah. Anyways.
Any other questions? No.
All right.
So we can move to the next presentation by Dr. Sharad.
Thank you, guys.
Thank you.
So can you see my screen?
Yes, sure.
We can see.
Yeah. Yeah. So I'm going to present a case of Impella-assisted chip CTO PCI in a severe LV dysfunction with significant hemodynamically significant mitral regurgitation patient. So my patient is 71-year-old male, diabetic, already underwent PTCA with stent to LAD, RAMS, and distal RCA in 2006, 2012, and had moderate LV dysfunction. And he's a drug defaulter. So he presented with acute coronary syndrome with non-QMI, twice hospitalized with a decompensated LV failure and pulmonary edema, and got stabilized medically and discharged. And after second admission, patient also underwent angiogram, which showed triple vessel disease. And when he came to us, so he was in sinus tachycardia with no STT changes. And I sent patient for echo. So by the time he walked the 10 to 20 meters, so patient went into severe SOB, and echo showed severe MR, and his pressure dropped to systolic pressure dropped to 90. So we admitted patient, and did BNP was elevated, TROP is significantly elevated, and renal function is fine. This is the echo, which is done in OPD when patient walked into my room. So you can see that there is a severe MR, so ischemic MR. I think it's more of dynamic. That was the reason why patient got admitted twice with a decompensated heart failure and pulmonary edema. And we can as well see the pulmonary artery pressure, which was quite significant in this patient. So this was the angiogram which was already done after second admission outside. So we can appreciate a significant lesion in ostral LCX. And there was a stent in ramus, but it was totally occluded. And ramus was filling from diagonal. And we can see this is the ramus which was totally occluded, and that was filling from diagonal. And there is there was a stunt in Constele LAD, and which was patent. And this is the right coronary artery. You can see it's a complete total occlusion, and we can see right coronary artery is filling from left system. So it's a very precarious anatomy. And these were the risk scores of the patient, high syntax score, high Euro score, high STS score, and CHIP score was around 10. And this is a JCTO score for CTO assessment, and there is cap is okay, clear cap, and length was quite huge. And there was a stunt here in right coronary artery. So it's an instant CTO as well as CTO extending even proximal to the stunt. So it's a quite long CTO and calcified vessel. So roughly it's a JCTO 2 or above. And we can see this is the overall situation which I was into in an advanced age, diabetic, heart failure with ACS presentation twice, and depressed LV and high PA pressure, severe MR. And when we look at anatomy, it's a very complex anatomy, like needs left main bifurcation, since he had ostial LCX tight lesion. And there was an RCA CTO, which might need retrograde because distal cap is at the bifurcation at the crux of RCA. And RCA was quite calcified, which might need atherectomy and guide extensions. So overall, it's a complex physiology, complex anatomy in comorbid conditions with high scores. So that clearly mandates a protected PCI for this patient. And we had a clear wiring strategy for this CTO. So he had these septal collaterals which were filling PDA. So this acts as a retrograde conduit for this patient. And since there is a stunt here, so it's an instant CTO, but CTO is already progressed proximally. So this stunt acts as a clear scaffold for wiring. So often we can complete antegrade. So retrograde is only if I cannot successfully do it antegradally. So the clear plan for wiring strategy was park a microcatheter proximal to CTO, and you escalate to Y. And what I have to do is I had to do is take this stunt into allocranial and arrowcaudal views, two orthogonal views, direct the wire into the middle of the stunt at the proximal end, and direct the same stunt at the middle of the stunt at the distal end, that is at the crux. So yeah, that's how it makes your job easy. Presence of stunt makes your antegrade wiring much easier. So that's how we can cross this lesion. Yes, obviously the challenges were hemodynamics, which we addressed with Impella support, and other thing is guide support for RCA PCI. So often I feel difficulty in taking AL when there is Impella inside aorta, but just now I have seen a case of RN where he used AL. It's possible, but often I feel it is difficult to navigate and cannulate RCA with AL in this kind of scenario. So we did a PA catheterization before procedure, so which clearly showed a PA pressure got reduced because the procedure was done almost 24 hours after patient admission. By then, we had started all anti-ischemics and diuretics, high-dose diuretics. That's how his PA pressure got reduced, which was almost 70 to 80 before. And you can also see the reflection in the CVP. CVP was also quite low. So we inserted Impella CP, and this was the baseline angio of left system. So we can see ostial LCX is tightly deceased. So what we did, an IVs from LAD just to note down where the stunt was ending. So stent was there till the ostium of the LAD. So once that is made sure by intravascular ultrasound, and then we went ahead and dilated, prepared the LC acceleration with 2.5 NC, and then we also did kissing both into LAD as well as LCX. As the LAD stunt MLAs were not good, we had to even dilate, LAD stunt, and then did kissing, and followed by we had to do a cutting balloon in LCX ostium. So this is flextome. I think it's Valverin 310 in LCX ostium. You can see there is circumferential calcium in proximal LCX, and followed by we stunted with kind of mini crush, followed by pot and kissing and repot. So this was a final result which I had got on left system, and every time I was dilating in ostial LCX, so we had pressure drop in for the patient, because that was the reason for his severe MR, along with total occlusion of right coronary artery. And we started RCS CTO PCI with JR guide. We can see here. So we took 3 arterial punctures. So we can use SHIP, but often it becomes difficult to again navigate your guide with the SHIP technique, especially 7 French guides becomes much more difficult. So that's the reason I used 3 arterial punctures. So you can see here, so it's a 𝐭𝐸 which was now sitting on proximal cap, and we can see the guide was quite hostile in its positioning, and I used an anchor wire, you can see, into RV branch, and also anchored a microcatheter with a balloon. So that's when you are using anchoring microcatheter, we end up in occluding vessel for quite a significant amount of time. That's when patients can even deteriorate. So with this kind of LV dysfunction and ischemic MR. So this is a 𝐼𝐻 wire, so which we navigated in 2 allocranial allocaudal views into the proximal end of the stent, and followed by further navigated towards distal end. But the problem was, as the guide support was not good, so the wire was not getting advanced to further. So that's when I changed to a slippery wire with similar tip load, that is Gladys Mango. So I took Gladys Mango, which is almost equivalent to the tip load of Gaia 2, and quite slippery. So to cross instant CTOs, it becomes much easier. So you can see this is Gladys Mango, which is advanced into the distal vessel with trapping microcatheter proximally with the balloon. So, and this is when patients can sometimes deteriorate. So once I crossed with the wire, advanced 𝐭𝐸 beyond the lesion, followed by removal of anchor wire. You can see here I removed anchor wire and pulled in guide extension catheter, because that's very important for further support to push anything into the CTO. Again, this guide extension such deep into the vessels also occludes vessel blood flow, and that's when patients can deteriorate sometimes, and that's what exactly happened even in this patient. I tried sending a 1 mm balloon, but it was not going. So we did granuloplasty here, but still it was not going. That next balloon was not going, so I had to do a laser. So we did laser through the guide extension, enter throat, enter lung, and followed by we moved on to next step. But at that stage, patient went into hypotension, and you can clearly see there is a VA discordance, which has been already presented by previous speakers. So there was a complete VA discordance, and because of Impella, flow and map was maintaining. That's mostly because of prolonged balloon occlusion of right coronary artery, as well as prolonged guide extension presence in the right coronary artery. Probably that would have caused a problem. So you can see the contraction of LV in the fluoro, which makes you understand there is something wrong. And at that stage, I had to again check left system just to make sure everything is okay on left side. So that was fine. So at CVP was quite 6 at that point of time. So we increased CVP to 10 to 12 by infusing IV fluids. And yeah, once the pressures got settled, I removed guide extension back into right coronary artery, gave time for patient to get back. And once patient got back with his hemodynamics and VA uncoupling disappeared, so we went on for further procedure here. So yeah, we wide PLVB using a 𝐻𝐼𝐴 catheter. So that's very important, yeah, and yeah, subsequently, this is wired, PLVB is wired, and then we went ahead stunted entire segment of CTO. So now you can see this is a final result which I had achieved in right coronary artery. And post-procedure hemodynamics, again, right heart catheterization done. So peer pressures were maintaining the same with a CVP of 9. So that's a good data. And we also look at mixed venous oxygen saturation. That was also good. And lactate was 2.2. So MAP was 85. And there was no inotropic support. And the urine output, everything was clear, good. And slowly we weaned off Impella support to P2 and looking at PA pressures as well as mixed venous oxygen saturations. So as everything was okay, then we removed Impella immediately and closed with Perclose, which was placed prior to the procedure, and then TPA was removed. And most important is, the residual syntax score was only 5. The only ramus was left, rest all were addressed. And that's very important in such patient, achieving a good residual syntax score. And that's the primary purpose of even using Impella assisted PCI for this patient. We can see his MR, MR is completely reduced in post-procedural echo. There was no MR, so, and it's mainly because ischemic and dynamic. So take-home message is hemodynamic support with Impella is the key in such cases like LV dysfunction, high PA pressures, or LV-EDP, or significant ischemic MR. Impella support makes procedure more predictable and avoiding hemodynamic interruptions, which is the key in handling such high risk and highly complex anatomies. Complete revascularization is possible only when hemodynamics are stable with MCS in such patients. Thank you.
Yeah, Sharath, it was a wonderful case, and I think once again it showed that there's an indication for protected PCI in such a difficult clinical patient subset. And my only concern would be when you said that the baseline CVP is around 4 or 5, did you load the patient after the Impella was inside? Because again, as you said, with a low EDP or low filling pressures, the Impella may not, it will actually add to more suction alert alarms, and lesser the preload, the more would be the risk of hemolysis.
Yeah. So yeah, after right heart catheterization, if CVP is low, in every case, we infuse patient with IV fluids, and most of these patients would be on diuretics. And we take CVP to 10 to 12 typically, before I proceed with, Impella. So because that's important, as you mentioned, suction is one thing, and another part is hemolysis. So when there is low preload, the risk of hemolysis also will be high. So yeah, typically that's the first thing which I do. I mean, I have done even in this case, but despite that, we ended up in noting down again low CVP when patient had kind of weird discordance in the middle of RCA PCI. Yeah. Again, we loaded patient with IV fluids.
All right. So this patient was also on a right heart catheterization.
Yes.
𝐭𝐶𝐬𝐬𝐜.
Yeah.
Yeah. Good.
Dr.
Right.
Praveen, just a question, because you have a larger experience now that the purge solutions, generally what is recommended now by the Biomed is the heparinized saline or heparinized dextrose. So do you consider the bicarb solutions now?
Not yet. I mean, I'm still using the same, but definitely we can use bicarb also in place of that. And I have no experience of using bicarb as yet. Yeah. Although, because most of our patients are actually requiring Impella, like 80% are protected PCI. Some patients, like one patient was continued for about 6 days or 7 days. The other one recently was about 3 days, and he started having some hemolysis at the second day, and we kind of gave some fluids, etc., reduced the hemoglobin, reduced the heparin, sorry, and then subsequently since he was getting stabilized, so we removed the Impella. But otherwise, we never switched over to. We were thinking of switching to soda bicarb, but this patient was managed without that. So anyone who has used soda bicarb, I think it'll be good to share that information. Dr. Bali, have you used it?
No, I haven't used it soda bicarb, but my question is to Sharath. If you can come to the case back. But before that, anybody wants to take about soda bicarb, that would be great.
No one.
Sharath, I have a little different take on your case. You look at the hemodynamics at the start of this patient. He had severe PH, and he had about 64 millimeters per minute artery pressure. And over a period of about 12 hours, 12 to 18 hours.
Yeah, more than 70. In 12 to 14 hours, it got reduced. Basically,
Yeah.
MR got reduced to moderate, and then
That's the point I'm trying to make, that this indicates that the MR was ischemic and dynamic. This all can't be decongested. So that there was a severe MR when the patient presented, and over a period of time, because the ischemia may have been dynamic, that reduced. So that was part of the hemodynamic process. The second part is that the culprit lesion here was the circumflex, ostial circumflex. So on IVUS, we found left main was normal. Ostial LAD was normal. And it's only the underexpanded stent in the proximal LAD.
Yeah.
So I think the RCA was CTO and was supplied by retrogradely by the left circumflex left system. So could we have just considered an ostial circumflex cutting balloon and a TAP and had got an optimum result? And come second stage, I'm saying that if it was not mandatory to use an MCS in a patient who has a dynamic, left ventricle dysfunction because of ischemic mitral regurgitation. So in such a patient, just do a cutting balloon and a dab of the circumflex and optimize that result on IVUS and optimize the underexpanded LAD stent with a balloon or an IVL and leave him there, because long-term results of a two-stent study is already going to be not as good as a single stent strategy. So we could have just got away with taking care of the ischemic lateral wall and mitral regurgitation by doing a cutting balloon and dab. So could that have been a possibility? And come back and done the right corner. And second question. Throughout the procedure, I saw that even though once you had done the left main bifurcation, the left main guide was still there. So that, to my mind, looked that I think that should have been out Because once we are optimized the result, we have done a good result, and we have seen that the antegrade wire has crossed into the distal lumen. The left guide should be out, because this is a patient where guide also can produce ischemia, and this patient did have a hypotension. So those are the technical issues I want you to point out.
Yeah, so yeah, I mean, I'll answer the second question. So why the guide was there? So as I mentioned, after crossing RCS CTO, and as a guide extension, see, you must have seen, to cross CTO, as the guide support was not good, I used trapping microcatheter. So the balloon was inflated almost like 15 to 20 minutes there inside the right coronary artery. I think that is what actually created a problem, but that's the only way I can do enhance my support in that case. There was no other way, I can enhance. I tried anchor balloon, I tried anchor wire, nothing worked. So that's when I had to move on to anchoring microcatheter in the main RCA. So that's when patient hemodynamically deteriorated. So that's the reason actually I had to continue keeping the left guide. See that I pushed left guide again, and saw what happened in the left system. So I think later on I left it there till the end of the procedure. Yes, it can be removed. That's not an issue. And second, coming to doing only a LCX and leaving patient. Yes, that's one option. If I had if patient was not ready for hemodynamic support, probably I would have done the same thing. Just do a quick angioplasty to LCX and come out and send the patient out. But MR, I mean, see, if you see, this is a non-dominant LCX. I'm not sure, whether that MR disappears completely, after opening LCX, because RCA was dominant, for this patient. That was one thing because of which actually I proposed complete revascularization to the patient. Because I had to do complete revascularization, I took help of, protected PCI. If patient was not ready, I think that was an alternative. I would have just done LCX and, come back and, try and treat RCA in later date. Yeah, that would have been a good choice if MR completely disappears. Yes.
Any other points from anyone? Dr. Bali, you're done. Yeah. Okay. So thank you very much.
Let's come to Praveen. Let's come to this question that should a complete revascularization be a guiding principle to put in a MCS, or should a hemodynamics be the guiding principle for an MCS? You can always come for a RCO, CTO second stage.
Absolutely. So this is always a question in mind, and we do not have the real answers to that. But this is the way many of us do also practice that. You do one vessel now and do the second vessel later, which is also a reasonably good idea. And maybe that this patient, which Dr. Sharad was doing, could have the MR would have improved with the opening of the circumflex, because it was giving collaterals to the RCA, and then subsequently, when everything was fine, he could have come back. So that could have been done, certainly. But sometimes, we have to evaluate whether we'll get a second chance, whether we are not going to get a second chance. And, so we have to evaluate everything in totality. And certainly, there are always two methods to do a situation, like you already mentioned. Why not just a cutting balloon and DEM? Of course, that works also fine. But certainly, nevertheless, these are also ways to handle the situation, which he did. And I think there is nothing wrong in that. And that's what it shows that, these are the ways patients can be managed successfully. That's my take on this aspect.
I think I've faced these questions many times when I had to do a multi-vessel PCI in such critical situations, especially when the patient is in cardiogenic shock. So perhaps you can always keep the Impella there and come back in 24 to 48 hours time. So it's all individualized decisions. I'm not sure whether we have any clear answers, Dr. Praveen said. So it will be dictated and the decisions will be governed by the clinical state and also the resources and various issues that may come by retaining the Impella for a longer period of time. So I've had some cases where at least 2 of my patients who were on Impella for 3 to 4 days had profound hemoglobinuria, hemolysis, and they had an acute kidney shutdown and was to be on CRRT and even SLED mode of dialysis. And it took almost, I would say, 6 months for their renal parameters to return back to the baseline because of the hemoglobinuria-induced tubular damage. So it can affect very profoundly and have such a. So we'll have to take such decisions on an individual basis as of now. But it's a good question that we always have to keep in mind and keep thinking about it whenever we face such situation.
Right. So I think if there are no more questions, we can now sum it up or just call it a day. So Gauravi, you can come in now.
Yes, thank you. Thank you so much. It was a very, very insightful session. So thank you so much, Praveen Chandra sir. And a big, big thank you to all our esteemed expert panelists, as well as speakers and the guest speaker as well. Also the participants for contributing to such an enlightening session. We are sure that today's session must have provided valuable insights to each one of you on managing complex PCI with Impella. Dear participants, on behalf of Veiva Scientific and 𝐴𝐈𝐿𝐼, we wish you all the best in your future endeavors, and we look forward to seeing you again at our upcoming sessions. Thank you so much. Have a wonderful evening ahead. Thank you, everyone.